finger.
Okay, now today we're going to get into some interesting territory. I think this was my own plan to do this. This is my evil mind at work here. Dr. Elisabeth Potter, you may have seen her. I believe it was on Instagram. Her video where she was attempting to get clearance for a surgery that I believe she was already performing, and of course the insurance company was obfuscating. We're going to get into the frustrations of practice of medicine. It's not going to be boring, trust me. You're going to finally hear what it's actually like. She is Emory-trained fellow and plastic surgeon, board certified via Princeton. She has all the credentials, and she's here to give us some experiences from the front line. And then quickly we'll speak with Dr. Eric Weiss, another plastic surgeon, talk about regenerative medicine. We've talked about stem cells before. We're going to get a little more into that and what its potential is in neurobiological processes. So stay with us. Be right back after this.
Our laws as it pertains to substances are draconian and bizarre. The psychopaths start this way. He was an alcoholic because of social media and pornography, PTSD, love addiction, fentanyl and heroin. Ridiculous. I'm a doctor, for sake. Where the hell do you think I learned that? I'm just saying, you go to treatment before you kill people. I am a clinician. I observe things about these chemicals. Let's just deal with what's real. We used to get these calls on Loveline all the time. Educate adolescents and to prevent and to treat. If you have trouble you can't stop and you want help stop it, I can help. I got a lot to say. I got a lot more to say.
I've spent most of my career dealing with illnesses that shorten life, and now we have ways to extend it and extend wellness. I've been working with the team over at V-Shred to develop a product that has everything I want in a longevity supplement. NR Boost has nicotinamide riboside. You know how metal can rust? Well, your body behaves in a similar way. It's mediated through something called NAD. NAD falls as we age, so we're less able to fight off that oxidative process. We oxidize much like that metal. And NAD fights it, but nicotinamide riboside elevates NAD so we can push back on those oxidative stressors, improving health, improving longevity. The other product is Senosync, has fisetin, one of the key molecules to fight off zombie cells, and we've added resveratrol to that, which is a well-known anti-aging antioxidant again. I don't like supplements that have a ton of ingredients. To me, it suggests that none of it's working. When I prescribe a medication, I prescribe that medicine because I expect that to work. That is exactly what I've done with these products. And I want you to go to drdrew.com/vshredmd for 10% off. Again, that is drdrew.com/vshredmd. You can follow Dr. Potter on Instagram. It's Dr. Elisabeth with an S, Potter, Potter. Also on X, it is ePotterMD, and Dr. Potter, Potter.com is the website. I will call her Elisabeth. You may call her Dr. Potter. Elisabeth, welcome to the program.
Thank you so much for having me. It's a thrill.
So tell people the story of what happened and what you were doing, what led to that video that I think a lot of people saw. In fact, once you set it up, I'm going to show the video if you don't mind. How much of it can we play, Caleb, without YouTube or somebody freaking out at us?
I'll play like the first 30 seconds and then turn the volume off. It'll be fine.
Okay, I think you do get the sense of your frustration very, very quickly. And so you tell me what led up to that, and then we'll play it. And then we'll talk about the consequences afterwards.
Great. So the day of this video, I did 4 breast reconstruction cases. I'm a plastic surgeon. 90% of my work is taking care of women affected by breast cancer. And during the 3rd case, I received a message in the operating room while I was operating. And it was from the nurse manager of the OR, saying that UnitedHealthcare was calling me and wanted to speak to me right now. And there's history there in breast reconstruction having difficulties with access through insurance. And UnitedHealthcare specifically had been at the forefront of denying a special type of reconstruction that I am a specialist in the past. So I immediately
what kind is that?
thought, deep flap. It's microsurgery. It's when you, instead of using an implant, you use your own tissue. It's healthier. It's lifelong. It doesn't have the foreign body reactions. It doesn't have all of the issues with implants and safety and all of that. It's a flap, and it's a flap that, so basically they try to equate a muscle including flap with a flap that doesn't include muscle. So like you can injure a patient and take both of her rectus muscles to make breasts, or you can be a really elegant, delicate surgeon and do a surgery that's hard on the surgeon and easy on the patient. And insurance tried to say that those were worth the same thing. And United was the first company that kind of sent me the letter saying, we're not going to pay you anymore for the delicate work. We're going to pay you at the barbaric surgery rate. So that had been happening.
Okay, so hold on. Let's stop right there. Let's just talk to people about that. So that doesn't surprise me at all. They squeeze down wherever they can, and the doctors just eat it. I have many, I'd say 30% of my services, maybe 50, ended up being free, and I just did it because it's the right thing to do. And the insurance company has in fact, they like that. They have no problem with that. So if you don't speak up, and when you do speak up, they are layers and layers and layers of bureaucracy in the way. So you're unable to get where you need to go. You actually literally have to hire somebody to do it. And then by that point, you've really undone whatever compensation you're trying to get. But this notion that they determine what's right for that patient. Isn't that the fundamental principle at issue here?
It is. And that the fight that I fought with the flap surgery it was so clear that there was something that was better for patients, but insurance companies.
Well, let's ask this. Is it longer under the knife? Are you in anesthesia longer with your
sometimes
procedure?
With my procedure,
do they
no.
Pay the anesthesiologist?
Yeah, they do. There's such a great.
Of course they do.
Of course they do. Of course, there's such a case to be made for doing the right thing here. I mean, it makes medical sense. It makes business sense. They just didn't want to do it. They wanted to squeeze the last dime out of doctors, and that was the history when I got that phone call. So I thought, what are they doing now? They're going to hurt this patient who's having surgery to treat breast cancer actively under anesthesia. And you're calling me in the operating room. I had another surgeon with me. We were finishing that case. And I said, hey, I think I better take this call because I'm thinking they might charge her cash for this, or she might get some exorbitant bill. She's already affected by breast cancer.
So our motivation, and I know this feeling because I have the same exact thing, which is I pay me or don't pay me, whatever. But I don't want this patient stuck with this bill. So my patients are all awake, and I end up saying to the patient, "Hey, the insurance company is called. I know they're gonna ask me to demand I discharge you tomorrow, and I don't want you to be stuck with anything beyond that." So I'll tell you my part of the story after we get through the surgical part. So let's watch the video of what happened in that interaction where you were literally called out of the operating room to deal with an insurance company, which that already in and of itself people should be freaked out about. Go ahead.
I just did 2 bilateral deeps and 2 bilateral tissue expanders for patients. And I've never had this happen before, but during the second deep, I got a phone call into the operating room saying that UnitedHealthcare wanted me to call them about one of the patients who was having surgery today, who was actually asleep having surgery. And, said I had to call right now. So I scrubbed out of my case and I called UnitedHealthcare, and the gentleman said he needed some information about her, wanted to know her diagnosis and whether her inpatient stay should be justified. And I was like, do you understand that she's asleep right now? And she has breast cancer. And the gentleman said, actually, I don't. That's a different department that would know that information.
All right. But that's actually not even the video I saw. You did one video where you were actually talking to the insurance company, right?
Oh, yes.
Isn't that? Yeah, that video, Caleb, you got to find that one because that's really what we go through.
I'll find it right now.
What's that?
Where'd you post that, Dr. Potter?
It's called a peer-to-peer review. Which,
I'll find it.
Yeah,
it's labeled deny.
And so in my world, where they say they want it used to be called doctor-to-doctor review, and then they switched the euphemism to peer-to-peer. I don't know why they did that. I'm guessing so they could, I don't know why. But at the point at which there was a doctor-to-doctor review, I knew there was a 0% probability of getting coverage. 0. No matter how sick the patient was, no matter how dangerous the circumstance, no matter how much time I wanted to give the patient, it was get them out of here. You don't know what you're doing. And it's always very, the guy at the other end in Ohio or wherever hell he is, he's typically males in my experience, in my world, was attacking and disdainful and just talk about peer-to-peer, anything but collegial. And of course, I don't know who he is or what training he has, and he doesn't see the patient in front of him, right? He's not there. He doesn't give a shit.
Yeah.
He's only motivated to save money for the insurance company.
It certainly feels that way. And I think the video that you're talking about, I just actually followed up with the patient whose procedure was denied yesterday, who I discussed in that call. And it was just insane, right? I mean, I get this phone call. First of all, it was a phone call with a cosmetic plastic surgeon and an ophthalmologist trained additionally in plastic surgery of the eyeball. Neither one treating breast cancer patients. When I asked them to give their name, their credentials, their license number, they declined. They cited their safety as the reason for that. Here I am trying to get a cancer patient treatment that's necessary to keep her working. She's actually a physician, needs to use her arms, doesn't want lymphedema. And then when they wouldn't give that to me, they said, it's for our safety because our CEO was murdered. And I said, I don't understand the connection. And I want to verify who you are because you're making a really important decision for this patient that I care a lot about. And then so when they wouldn't give me that, I tried to verify in some other ways by asking some questions. So yeah, here's the call.
Here's the video. Here it is right here.
Who am I speaking with? Can you not, there's also another way. So you have two doctors on the call. Will either of you give me your name or MPI number or license number? Be the reference number for the call, but you won't give me your name or number, and neither will the doctor from Texas. Okay, please give me the reference number. Okay, and is the doctor from Texas? Would that person speak up, please? I'm good. Are you a plastic surgeon? What do you mean subspecialty plastics? I'm a plastic surgeon. I wouldn't say subspecialty. So you're an oculoplastic surgeon. What was your initial training in? So we're speaking about lymphedema of the arm. So this is not an area that you're familiar with, correct? Oh, okay. Still practicing, but you won't give me your name? But you're my colleague in plastic surgery, and you won't give me your name. Yeah, I don't understand how it's connected. I understand that the CEO was murdered, right? But I'm your peer, and I want to have a conversation with a peer about a patient who has breast cancer and lymphedema, and I would like to know your name. How do I know who you are? How do I know that you're board certified and that you're a microsurgeon? How do I verify that? I'm just trying to make sure that I'm talking to
They're for sure not, right?
In this procedure.
Correct.
Sure
so I went on to ask questions. So have you ever performed this surgery? Even once?
Yeah.
No.
Yeah.
Do you know?
Have you ever seen it performed?
Yeah. Do you know even the risk that this patient is facing? Just the percentage risk. Do you have a basic level of understanding? Did you read a paper before you called me? No. Mm-hmm. So, I think America needs to understand what we're dealing with, and that was just for show. There was no chance of, and then they followed up by saying, we actually don't have the ability to approve this procedure on this call. That's not in our role. And I'm like, then what are we doing?
Right.
Why are you putting me and the patient through this?
In the meantime, you spend God knows how much time and multiple calls, right? That's not the only call. There were multiple calls and multiple paperworks.
To get to that place,
they're doing anything to get in the way of your doing your job and getting and I'm sure their reimbursement, you said it was already squeezed down to the level of just a regular procedure, but even before it was squeezed down, it was probably squeezed down.
Correct. And a couple of things I'd say. They also had no idea of the patients. That's their member who's been paying premiums into United. They didn't know that this patient needed radiation. They actually questioned me she doesn't. And I'm like, oh yes, she does. She's having an axillary dissection and radiation. They weren't aware even of their members' details. It's just shocking.
Let me tell you a story that really alerted me how bad things were. And this was in the 90s. So if you want to know how long this has been going on the medical, the general medical and the psychiatric, I worked in both general medicine and psychiatry, and really egregious on the psychiatric end, really bad on the medical. But the psychiatric end, when I really knew we were in trouble is when I got a call from an HMO administrator who was a physician. And he said, he's actually a good doctor, I thought. And I'll never forget this conversation as long as I live. He said, I want a 3-day detox rate. And whatever the rate was going to be something markedly lower than what it actually cost to take care of the patient. But that wasn't the issue. I said, look, we're starting to see your patients. You require them to be discharged in 3 days. It's demoralizing my staff. I said, I'll tell you what, you name your price, anything. I was offering him the world, and I'll treat them across levels of care. We have outpatient and residential. I'll figure out where to put your patient, and I'll take the risk. You name your price. He goes, no, I want a 3-day detox. I go, what are you talking about? Do you imagine that after they have a 3-day detox, they're not going to go out, that's treatment, they're not going to go out and use? He goes, oh no, they'll go out and use. But if they do that 3 times, then they lose their job. Then they're no longer my concern.
And there you have it. There you have it.
God is my witness. That was the conversation because it was seared into my mind. It was seared into my mind. And then in the 2000s, things got worse, believe it or not. Because then when the insurance would split you with the patients, claiming that, oh no, we have coverage for you, just Dr. Pinsky's got to tell us what you need. They don't tell the patient that they set all the criteria. And the criteria are insane. They have to be like imminently, need a ventilator or imminent, gun to the head, suicidal or something. Just stupid shit that, of course, nobody makes that criteria. Not the fact that they've been on the street, on heroin, with a, TB, with a leg infection. None of that matters. Get them out. Get them to some other level of care immediately. So, all right. So the patient discharges, they kill themselves, and the insurance company goes, well, we don't practice medicine. There's Dr. Pinsky's signature on the discharge order. It has nothing to do with us. Yes. Then I complain to the insurance commissioner. Next thing I get, I actually went through this, is a call from the CEO of the hospital freaking out. This insurance company, a big one, is threatening to decertify the entire hospital because I don't approve of their business practices. So this is how they do it. This is how they do it.
It is.
And the American people don't understand it. And now, Elisabeth, well, I'll go back to the insurance in a section, but COVID laid bare all the other influences that doctors are under that I wasn't under when I was very active practicing. Employees, departments of public health that are mandating behavior rather than advising behavior of physicians, medical boards that are rapacious. What did you see during that period?
Oh gosh, during COVID, what a nightmare. So as someone who takes care of women with breast cancer, I remember very clearly, I have patients who needed surgery. I mean, they're getting cancer. And the hospital said to me, well, you're going to be able to, we have to modify the surgeries we're going to do. We can only, kind of treat them, not fully treat them. And they can't have their reconstruction because we think that's elective. We think that's cosmetic surgery. And I'm like, wait a minute, there's a federal act that says that this is not elective surgery. And I can do really fast. I'll be super efficient. Like I'm not going to use up extra resources, but women aren't going to get their mastectomies if they can't get reconstruction during this period. And they just said no. And that's actually when I decided to build my own surgery center because I was like, I will not. Women's health in general is so embattled. We have to beg, borrow, and steal for good care. And when they said, we'll let the orthopedic surgeons do their joint replacements during COVID, but we're not going to let women get breast reconstruction, I said, okay, now's the time that I invest in myself and I build this surgery center.
I want to stop and say 2 things. A, it woke a lot of people up to a lot of things and forced creative solutions. And I'm so glad to hear you were one of those people, number 1. But number 2, everybody, again, the purpose of today's show is to wake people up to what's happening to American healthcare. When you centralize authority, you harm patients. That doctor across the screen from me or me, we're the only people actually responsible for you when we see you. Nobody else is. It's us. And if anybody adulterates what we're doing, they're screwing with our ability to represent your best interest, which is all we're doing. That's all we do. And this is a bad thing. This is a bad situation when healthcare providers, insurance companies, federal government, public health officials, for God's sake, CDC, they never were intended for this. These were advisory groups to give us information for us to form those judgments to do the best thing for our patient. Mandates where the government tells you what you can do with your body. mind-blowing. And you're much younger than I am.
insane.
For me, it's super mind-blowing. What was your training with at Princeton? Was it a scientist, you biologist?
Molecular biology. Molecular biology.
So give me you're probably the youngest physician I've talked to who has these instincts that some of us 50 and above have, just like crazy.
I'm 49. You're sweet.
Okay,
I'm 49. I'm a plastic surgeon.
You're right under the threshold of what I've been saying. As a scientist, I bet you have a whole other set of concerns.
I do. And listen, I mean, I just think that we have to have a system where doctors in front of the patient can weigh the individual circumstance of that patient, consider the medications available, consider the testing that needs to be done. And absolutely. And then order it. I mean, what you have now is you have insurance companies in the room as the strongest voice in the room that I'm having to filter. I'm having to ask permission to then enact my plan of care. That has never happened before. Now we have companies who have a fiduciary responsibility to their shareholders to maximize profits on one hand, and they have more power than the doctors who are the only ones in the room who have an oath to protect the patient. That should make patients very nervous. And we're at a at a fever pitch.
You know what? The surgeons, I noticed during COVID, the surgeons were just like, they were very quiet and they were just doing things. They were doing stuff. And I thought, oh yeah, surgeons, people, these forces can't reach into the operating room. They can't get into the space you guys are operating in. You're there improvising, making decisions throughout the procedure, and they can't get in the way of that. You're accustomed to being free to do that. But I thought to myself, and that's why I brought you in here. Oh no, they're going to get involved somehow. I just know it. They're going to inject themselves into the surgeon's life too. This is a new thing, that surgeons are getting nailed the way we have been for the last 20 years. So welcome on board.
My father
help us fix this.
Well, my father is an allergist and immunologist. My mom is a nurse. My mom said, when I finally told her about what was going on with United, she said that if they had asked her, she would have told them not to mess with me because this wasn't going to go well. I mean, I wasn't just going to, roll over and play nice for them. Yeah. And I think you're right. I think for a long time that surgeons were in this sort of room that no one could enter, but insurance is in the OR. They tell me what implants I can use.
Yeah.
They tell me, how much anesthesia we can do. They tell me how long I can keep my patient in the hospital. They tell me if they want me to take a patient's muscle or leave it. I mean, they are practicing medicine, and this system is set up to actually harm, not to protect patients from harm. Right. So I'm the advocate. I'm trying my best to hold the line. And that's right. And there's no respect for that. Right. So if I was a patient and I am a patient.
The wolf is in charge of the chicken coop. And
1,000%.
Whatever was in that guarding the sheepdog. We're the sheepdog, essentially, guarding the sheep. We're on a leash. We're on a leash or we're in a bear trap.
There used to be a sense that I thought that I could, in a measured way, have the last word. Like there was a card that I, as a surgeon, could play where I'm like, no, we're doing the right thing. And that no longer exists. Like with my patient with the peer-to-peer, they denied the service. She had her axillary dissection. She's going to, so here to your point about, if the patient commits suicide, they're no longer covered. They actually, they denied the lymphovenous bypass. This patient's now going to pay cash for it out of her own pocket. And I'm thinking, does the insurance company see that as a win? It's scary.
Yes, they do. Yeah. Yes, they do. They don't care. It's a win when the patient pays and you get zero. Because I've been through it. I've been around it a lot. I just go forget it. I'm not going to fight it. It's not worth it. And just give the service, do what's right, and that's that. And I don't think there's any other profession. People don't believe that doctors do that. We do it all the time. There's no other profession on earth that does that kind of thing. And we just do it. And because we do it, they keep grinding down. They know what they're doing. We are so trained to put the patient first in all situations that when it gets bad, we put the patient first and eat it. That's just the way it goes.
And I truly love that about medicine. Like, this is my calling. And because it's my calling, I've had to put myself in the line of fire of insurance companies for this. Yeah. So now I'm living it.
Well, here's there are three things I want to talk about. So stay with us, everybody. Sorry. I want to know if anything happened to you as a result of this. Like, were you punished by like me, the insurance commissioner comes in, or the insurance company freaks out? I want to talk about women's health. I want to talk about so many things. Hold on here. There was something else that we were just talking about that I wanted to get into. Don't get the aging brain. Don't do that. It's very frustrating. Working memory shrinks. It's terrible. Okay, but I do want to talk. The women's health is a huge topic. What happened to you? I'm interested to know. And then during the break, I'll think of the other topic and I'll open with that. So everybody stay with us, pay attention. We stand by everything that supports us here. So support them so we can keep doing this. I'm excited to bring you a new product, a new supplement, Fatty. I take it. I make Susan take it. My whole family takes it. This comes out of, believe it or not, dolphin research. The Navy maintains a fleet of dolphins. And a brilliant veterinarian recognized that these dolphins sometimes developed a syndrome identical to our Alzheimer's disease. Those dolphins were deficient in a particular fatty acid. She replaced the fatty acid, and they didn't get the Alzheimer's. Humans have the same issue, and we are more deficient in this particular fatty acid than ever before. And a simple replacement of this fatty acid called C15 will help us prevent these syndromes. It's published in a recent journal called Metabolites. It's a new nutritional C15, pentadecanoic acid it's called. The deficiency that we are developing for C15 creates something called the cellular fragility syndrome. This is the first nutritional deficiency syndrome to be discovered in 75 years and may be affecting us in many ways, and as many as 1 in 3 of us. This is an important breakthrough. Take advantage of it. Go to fatty15.com/Dr. Drew to receive 15% off a 90-day starter kit subscription, or use code Dr. Drew at checkout for that 15% off, or just go to our website, drdrew.com/fatty15. Weight loss and gum loss, the wellness company's got you covered with new products. Drop. It's for aggressive appetite control. It comes in easy-to-use liquid drops. No prescription, no painful shot. It is an oral peptide called retatrutide. It actually mimics the way the body naturally loses weight, and it is designed to support faster, more focused weight loss when combined with healthy eating and exercise. And Smile, it's a breakthrough fluoride-free peptide toothpaste. It gently whitens and reverses gum loss, actually rebuilding tissue at its source with a proprietary blend of peptides, remineralizers, and soothing botanicals. Go to drdrew.com/TWC for more information on Drop and Smile, and check out another new and innovative solution for hair loss called Roots while you're there. That's drdrew.com/TWC for 10% off.
And that suggests trouble in a relationship.
Sean, who are you? Like Dr. Drew all of a sudden?
I remember what I want to talk about. Elisabeth Potter is here with us, plastic surgeon. As I've said, you can follow her and get all her stuff here. There we go. Dr. Elisabeth with an S, Potter, Potter on Instagram, ePotterMD on X, and drpotter.com. So what I was going to ask was, did you have a sense that something was something was amiss with our medical literature during COVID? I just thought, oh boy. What did you, I read widely, and all of us, and I lean on it, I rely on it, and I saw something during COVID that bothered me. Did you notice anything?
I'd say, there was a lot that was wrong during COVID, and things just the whole apple cart got upended. And for me, my world is breast reconstruction and breast cancer, and so many things took precedence. It was like there was something was pushing us in a direction away from the care that we knew we should be giving. Right. So yeah, it was, I would say for me, it was just a hard time to get the patients the care that I knew they needed. How about the medical publications? Did you just stop doing the usual studies you read about? They just research in breast cancer just sort of stopped? Well, a lot of things stopped. It was crazy. I mean, and that's still going on today. And we're still seeing the effects of, not just stopping the research, but also, and it did stop. I mean, there were clinical trials that stopped. There were treatments that stopped. People weren't able to get the medications that they needed or the surgeries that they needed. And then we saw this, as you know, this increase in the rates of really aggressive cancers. And we're still seeing that. So it's...
Well, now let's talk about that, because I keep hearing that that's not happening. And yet the same people that say that, by the way, are saying there's no vaccine reactions. I'm seeing lots of vaccine reactions. What do you think that is? Is it COVID? Is it the spike protein? Is it natural killer fall off? What do you imagine is happening?
So, yeah, and I would say I'm not an immunologist. My dad was. And I did actually, I grew up reading the Morbidity and Mortality Weekly as like a table side magazine. But for me, it was more the fact that women just weren't getting mammograms. They weren't getting screened. They were not going to the doctor. They were fearful. They were mistrustful of the medical establishment. I mean, there was just a lot going on and people didn't get preventative care. And so we saw this increase in diagnoses and delayed diagnoses that were still unraveling. Now, my average patient age here in Austin, and I saw 35 patients today. I'll see another 25 tomorrow in clinic. I take care of 40% of the women in Central Texas with breast cancer. And I think my average age is in the 50s, which is young. And it's not, if you look nationally, that's not the age that they would say, but I'm seeing younger and younger patients with breast cancer.
Something is up. It's not a massive shift, but something is up. If you're in the fields, you see this kind of movement. I wonder it's that spike has protein effects on human physiology. I'm starting to worry about natural killer function, but you and I are not going to solve that problem here today, nor should people listen to us till more data comes in. But what happened to you as a result of that video?
I got a lot of support from patients who said, thanks for sharing that. A lot of support from doctors who said, I want my voice to be heard. I'm scared to speak out because I'm employed. Thank you for saying what I've been wanting to say. And a lot of folks said, I think that a lot of patients didn't understand that doctors were facing such difficulties getting them the care that they wanted to give. And so there was a sense of like, wait a minute, we're on the same side now. Doctors and patients are on the same side fighting for good health care. So those were good things. But then I got a threatening letter from United. It was 6 pages from the defamation law firm Claire Locke out of DC, demanding that I apologize and recant my video, and that, saying that I had promoted violence by not deleting comments that referenced Luigi Mangione. Meanwhile, I'm like a microsurgeon. I'm not reading the comments, So that happened, and that was crazy. I got really good legal counsel, and we published that letter so that all of America could read how UnitedHealthcare spoke to a microsurgeon who is taking care of women with breast cancer through insurance. And I think America read it, and they were offended along with me. But then this other thing kind of started to unfold where I have a surgery center. I'm actually sitting in that surgery center, and we were trying to get in network with all the major carriers, and United is the biggest, obviously. And I was hopeful when I spoke out. I was hopeful that they wouldn't conflate those things. But after my video, they went radio silent in our discussions with our consultant to contract. And since then, they've, they haven't let me in network, and that's been financially devastating to me. So my reality right now is that I'm a microsurgeon, Princeton, MD Anderson, Emory, UT Southwestern. I did 500 breast reconstruction surgeries last year. And I'm facing bankruptcy if I can't figure something out in the next, several months, simply because United won't let me in network.
What do you imagine your options are?
So I'm going to pivot hard. I mean, I'm not someone who's going to get pushed over, and I'm not going down behind insurance. I'm going to figure out a way to, motivate folks to get insurance that actually cares for patients. I'm going to help promote those direct care products that are rethinking how we deliver insurance. Going back to the old model where it was like a group of farmers who said, let's all put our money in a pot and take care of each other. Those things exist today.
Have you talked to Simone Gold at all?
No.
I got to put you guys together. I think there's something here. There are like-minded physicians all over the place. And we're all looking at the same thing and going, that's what the wellness company thing was for me. It's like, we just got to get things to the patient. We got to get everything possible to the patient. Their freedom to use some sort of healthcare something, to get access to medication, to get, we just got to get, we have lost our ability to practice medicine in a way that is in the best interest of the patient. So we need to get everything to the patient and show them how to make good decisions on their own behalf. That's where we're at right now.
And honestly, I think that the insurance, like patients paying $2,000 a month for healthcare and then getting sick and then having to pay $5,000 towards their, copay and then another $20,000 out of pocket. Like, this is a scam. This is not what healthcare should be. And so I'm interested in promoting those.
To remind yourself that 30-40% goes to the executive structure and the administrative structure, not going to your healthcare.
How about the fact that United spent probably $100,000 sending me that letter from Claire Locke?
Yeah.
I mean, United members, can you believe that your money is being spent sending that to this lady? That's crazy.
Isn't that the same? Right. Isn't that the same law firm that just sent a letter to Candace Owens?
Correct.
On behalf of Emmanuel Macron?
Yes, you're correct. It is. And I just can't even believe that United's money, these people are paying it and that's going towards me. But my granddad always told me that if someone wasn't mad at you, you weren't doing it right. And I think that, I've got a lot of evidence that I'm doing something at least a little bit right. So
she didn't tell you it wouldn't be fun. It's no fun making people angry.
It is 0% fun. Oh, but it's good.
Surgery is fun for you. You like doing that stuff, and you're being prevented from doing it. There are like-minded people. I got to put you in touch with some of these folks, and it seems like you should be able to sell your surgery center and just be a surgeon that operates at that center, then, or something. You know what I mean? It should be something like that you could do.
If there's someone listening who has an idea and wants to invest in a lady who's just like honest to God, a good person, taking care of women with breast cancer, call me up. I'll do anything to keep going in this work. I started a GoFundMe. I started a GoFundMe. We raised almost $600,000. The average donation is $70.
Crazy.
$70.
Wow. Yeah. Amazing.
So That's crazy. I'm hustling.
Well, let's quickly slide over to women's health, which
please.
It's like, let's slide over to cardiology and just discuss cardiology for 5 minutes. It's a gigantic topic, does not get enough attention. What is your take on our shortcomings there?
Oh, gosh. There's so much that we need to do better for women. Just including women in clinical research studies in a way that's thoughtful. Let's do that.
Mm-hmm.
Let's treat women respectfully and give them options, and let's fund women's healthcare in a way that's has parity with healthcare for the other half of the population. I think breast reconstruction is one of those things that really shows how underappreciated and undervalued women's healthcare is. We've had to fight just to keep access to the basics of care. And still today, I'll have phone calls where a doctor will tell me, isn't that cosmetic surgery? And I'm like, no, it is not. This is not elective. This is about women's health, and we have to do the right thing. So yeah, I'm a huge proponent for women's health and choice and being able to access the very best. I'm committed to that. I've always fought for the underdog. I'm amazed by the things that women do when you take care of them. I think if we want to change things for the better, we need to listen to women.
What did that? You caught my interest there. What do you mean by that? Amazed by the things that women do when you take care of them.
When a woman has the energy, when she just mentally, physically taken care of. You see what moms do? Do you see the level of energy? They just go to another level. When I look around and I see the women who work with me, they just, honestly, they're used to carrying weights. And when you free them up to just race, they do amazing things because of the weight that they've been carrying. They have been training to just crush it. And if we can just unleash women to do good, And I see that in healthcare. I see in my female surgery colleagues, they just do amazing things. They don't get ruffled. They just, buckle down and do hard things.
Speaking of carrying waste, one of the areas that women have been encumbered needlessly, in my humble opinion, is once their ovaries shut down, the postmenopausal interval and perimenopausal interval. And it's so odd to me, the bias. A thyroid shuts down, we replace it with physiological hormone. Why don't we do that to these sex organs? They shuts down, has massive effect on the body, as much as thyroid, certainly in most situations, maybe more, certainly in terms of ability to function in life and misery. And we go, oh, no, I don't think we want to do that. That's insane, in my opinion.
It is insane. And it's another example of how the medical establishment for so many years didn't take care of the actual science. They just didn't take care of business when it came to women. Yeah. I was trained in medical school that estrogen, caused uterine cancer and blood clots. And everybody be scared. Don't give it to your patients.
Listen, the New England Journal of Medicine published a editorial after that Women's Health Initiative. This must have been in the 90s, that you were literally, because I was like, I don't think I'm going to take these women off estrogen. I see how much better they are. What are we talking about here? Something's wrong with this study. And of course, now we know it was deeply flawed. But the editorial that worried me and caused me to talk to all my patients on estrogen said, we are no better than witch doctors. That was the phrase. You are a witch doctor if you continue estrogen therapy because the science is in. Sounds familiar, right? Sounds just like COVID all over again. But we did that. We did that to women in the 90s. Then we went, sorry, I made a mistake. No, sorry.
And not just made a mistake, caused osteoporotic fractures, caused dementia, caused cardiovascular disease.
What I saw was the cognitive decline. I had other ways to deal with the osteoporosis, right? We have, reclass and things like that. But in terms of, and thank God we started to have that stuff right then. We had Fosamax back then. But the effect on cognition and affect and relationships and so many aspects of their life ruined because of that study. And no one said, truly, I'm sorry.
No, and God bless Mary Claire Haver and all the women out there fighting this fight and going to the FDA and demanding better. And that is going to be huge for women's health. That already is. And it is a cautionary tale that a whole group of doctors believed that study for a decade or more.
Elizabeth, what did we do during COVID? We're still doing it. We're still not even willing to talk about things because people are afraid to talk about it. It's crazy. But let's stop on that one. Last thought, because I want to bring Dr. Weiss in here in just a second. I suspect we'll be talking again in the future. So we'll wrap it up with: is the HHS, in your opinion, moving in a good direction right now?
Oh gosh, can we have a little bit?
Sorry about that. That's a big question.
It's a big question. And so I have to look at, I'll be real specific. So the recent announcement about prior authorization reform, where the HHS, had basically a press conference with AHIP, the insurance society. And they said, we're going to allow the insurance companies to promise to do better, on prior authorization. I like the idea of noting the problem publicly. Authorization is a huge problem. I don't like the idea of asking bad actors to voluntarily police themselves. So, I like the general direction, but I would like to see teeth behind the directives.
Yeah, there are so many things that they're moving cautiously, which I like because I don't want them throwing the baby out with the bathwater. But my sense is that these things will have to be shaped further. Many things they're doing as time goes on, and I want to give them the time and the space to do that. I tell you, look to Jay Bhattacharya. That should be your. I don't want to say this guy got in trouble saying things like that during COVID, but let him be your guidepost as how things are going. at the HHS because he's very, very astute and very good human beings and not a bad actor, that's for sure. And
I would love,
and a good
I would love
scientist.
to meet with them. Yeah.
He's a good guy. So, well, listen, I appreciate you meeting with us. I appreciate you spending time here. If you could pick one place where people should go to find you if they want to follow up on this or they need help with these procedures, where would you like people to go?
Honestly, I'd say Instagram. That's kind of my home on social media. And
Okay.
I go there to tell folks what I'm doing. So yeah, find me on Instagram. It's Dr. Elisabeth Potter. Thanks for caring. Thanks so much for having me. I really appreciate you.
Well, you are fighting the good fight. So we appreciate you. Thank you, Elizabeth.
Thanks so much.
You got it. All right. So we're going to switch gears here and we're going to talk a little bit about functional and what should we call this? Regenerative medicine. Dr. Eric Weiss is a board certified plastic surgeon as well, and he's a leader in regenerative medicine. And he has been using stem cells, amongst other things, to treat non-neuronormative patients, including, I believe, somebody in his own family. He has a book called Educating Marston, where he elaborates this story. You can find Dr. Weiss at educatingmarston.com, North Florida STEM C on Instagram, North Florida STEM C, northfloridastemcells.com. So, Dr. Eric Weiss.
Non-normative
non-normative would be like autism. People that are not. You're a little non-normative.
Can I get this?
Does it help ADD, Dr. Weiss?
Yeah.
Sure. All right. Tell us how you got into this, what your thoughts are on it, and we appreciate you being here.
Well, I'm classically trained. I'm a plastic surgeon like Dr. Potts. But to make a long story short, my life changed with my youngest child. He had autism. And I felt that there was something you could do. I always felt it was a medical problem and not a behavior or a psychological problem. And
of course.
I kept up on the literature. You could see stuff starting to happen. But the landmark trial, I think even if you ask most pediatricians, what's the fundamental problem with autistic kids, that they would have a blank stare. But in 2005, there was an autopsy study by John Hopkins, and they showed 100% of the kids had brain inflammation, clearly abnormal brain pathology. They followed that up with.
Can I stop you? I'm sorry, we have a little delay, so I have to interrupt. But what kind of inflammation? I mean, that's a pretty broad statement. Where was it? What was it? What did they see specifically?
It was sporadic, but it was one particular cell, the glial cell. So it wasn't of the neurons. It was of the glial cell, which is the only kind of non-neuron cell in the brain, or not neuroectodermally derived. It's a myeloid cell. So it's like the monocyte of the brain, and the tremendous amount of neuroinflammation mediated through the glial cells.
So I'm sorry, I'm going to push a little hard because I really want to get the bottom of this. It's very interesting to me. So the glial cells themselves. So although I'm used to the glial cells being the cells that are wrapped around the neurons, and they're also in and around the neurons. So which the oligodendrocytes, is that what we're talking about, or what are we talking about?
No, the oligodendrocytes make myelin. And so, but about 10% of the actual cells in your brain are the myeloid cells, and they respond to certain things. And they're also very important in formation of the brain. They snip or they pair synapses that are not being used, and they can also help form new synapses. But the ones that were mostly, it was sporadic, it was throughout the brain, but prefrontal cortex. And then in our brain, we have a lot of white matter tracts. So different parts of the brain can communicate much better. And those were actually decreased. And they also had less connections in their brain than most people.
And how old was this? It was a series of subjects, and what was the sort of age range on that? Because again, I'm thinking if you're going to intervene on this inflammation, you better do it early so it doesn't cause permanent stuff.
Correct. The children ranged kind of between 4 and 11, but there were two outliers. There was a 33-year-old and a 42-year-old. But the 33-year-old and the 42-year-old had the same brain pathology, which we'll talk about my son, because when some other things happened, my son was 23 when I wanted to treat him. And they kind of said, well, he's too far gone. We don't treat, anybody really post-adolescent. And the more I read, the more I said, if the older people have the same pathology, why wouldn't it help? And it turned out it did help. And now Duke's doing a study on young adults, 18 to 26-year-olds, using stem cells.
How did you get to stem cells as a solution? Where did you see that?
Well, it came from Duke, but how it came from Duke was the pathology was defined at Hopkins, and they said, okay, we have this brain inflammation. And then that was 2005, kind of 2007, 2008, 2009 is when, chronic traumatic encephalopathy was big with the football players. And so the traumatic brain injury people were looking at that. And CTE turns out to be a problem with the glial cell as well. And so when they knew the glial cell was inflamed, they did a trial. They actually did 30 trials. The 30th thing they tried was umbilical cord blood, because they knew that umbilical cord blood and its stem cells had broad anti-inflammatory effects. And so they showed that not only did the stem cells from umbilical cord blood stop the inflammation, but it turned on neural restoration. These glial cells can secrete multiple factors, but there's kind of a pro-inflammatory stage. There's a pro-restorative stage. And so when they showed that, Duke understood that cerebral palsy is a neuroinflammatory disease, and they understood autism was a neuroinflammatory disease. So their first study was on cerebral palsy patients. 88% got better with stem cell infusion. And then they did autism, and about 65% of the kids got significantly better, within 95% confidence limits. It couldn't be explained. But more importantly, by MRI, after a single dose of stem cells, they had more synapses in their brain, and they had more white matter tract growth. And I went to Duke. I went to Duke Medical School. I knew some of the people involved in the study. So as soon as that was published, I called them, and they just said, Eric, we're seeing some incredible stuff here. But, obviously I asked to treat my son, and they said, no, he's too old. We do pediatrics. I actually called Panama. Panama is big in the stem cell world. They've been doing it for a while. I became disillusioned with Panama because I wanted to talk to a doctor. I wanted to talk to somebody who was going to treat my child. And I was, talking to salespeople. And then finally they said they wouldn't treat anybody over the age of 19. And then finally I found Thomas Loeb, who was a pediatric surgeon in Chicago. Very well trained. He was the head of pediatric surgery at St. Jude's Children's Hospital for 20 years. And he was very familiar with stem cells, and he had a pediatric brain injury study using it. And after talking to him, he came up, and said, why don't you bring your son up to Chicago and we'll treat him on a compassionate need basis. And that's what he did. And my son got remarkably better. And he showed me how to do it. And I've been doing it. I did it for my son. And, we all get pushed by our wives. And my wife said, are you planning on helping our son and nobody else? Because my son currently lives on his own, drives a car, and has a job, and is completely conversant. And before stem cells, he had maybe 30 to 40 words. He could put 2 words together, but he could do none of those things. And so my wife said, you have to take care of autistic kids. And I said, okay, a half a day a week. And then it became a full day a week. Then it became a day and a half a week. Then it became 2 days a week. And then in February, I gave up plastic surgery. And I've been doing this full time.
Amazing. And again, what is the treatment? Is a systemic infusion of stem cell? And what's the source? Is it Wharton's jelly? I mean, what are we talking about?
A little bit of both. The Duke study was done with umbilical cord blood as opposed to Wharton's jelly. And I think they both have good things, but it is a systemic infusion. These cells have the ability to cross the blood-brain barrier, and they actually seek out inflammation. And they work in what we call paracrine function. So they seek out inflammation, they nestle up to the inflamed cells, and they actually secrete factors. It's called the secretome. One of those factors are exosomes. The exosome then leaves the stem cell, enters the glial cell, and then turns off the glial cell from the inflammatory state to the restorative state. And we now know when a glial cell becomes in the restorative state, it secretes two main factors, something called brain-derived neurotrophic factor, which makes more synapses, and something that's called nerve growth factor, which makes your stem cells, which are deep within the brain, migrate to the area and start to differentiate. And the Duke MRI study backed that up, which showed new growth and more connections.
Again, people they imagine that the stem cells themselves go where they're supposed to go and form new connections. No, they're anti-inflammatory and pro-growth. It's the activation of a physiology that is nascent in the brain.
Exactly. And that a lot of people think they become part of you, but they don't.
No,
they turn on the body's ability to heal itself. I couldn't have said it better.
What percentage of kids are responding, and what's the sort of response range?
The response rate is probably closer to 65 to 70%. And the big question is, why don't 30% respond? And I'll answer that later, because I think now that I've given up surgery, I'm starting to find some other things that are important to do. But it ranges from having the kid just more present, that they're not in a fantasy world anymore. But I've had kids go from special needs schools to regular schools. I've had kids that didn't talk, start talking, kids that weren't potty trained, become potty trained.
And do you have to keep repeating the infusions? How long is the course of treatment?
There's never been a study of more than one treatment. The paper was released in 2019, followed by the pandemic. And like we talked about with Dr. Potter, or you talked about with Dr. Potter, all sorts of research got shut down. And so the Duke study showed that what they did was they gave the stem cells, then they tested the kids every month. And they noticed that they started to see growth, better improvements on the autism rating scale starting at 2 months. It peaked between 6 and 7 months, but they followed these kids for a year. After that, a total of 18 months, and there was no decrease. So we know that the improvement kind of peaks at 6 to 7 months. And the question is, what do you do then? Do you give another dose? And certainly I do. Probably 40% of my patients come back for a second dose, and we see further gains.
Are there, not to get off track here too far, but are there other conditions you're looking at? Uh-oh. Did we freeze?
How about that?
There you are. You froze for a second. Go ahead.
Okay. Any neurodegenerative disorder that we really know about starts with neuroinflammation. Alzheimer's, multiple sclerosis, Parkinson's disease, chronic traumatic encephalopathy, etc.
ALS?
So, ALS, yes. I think it's going to be more preventative than actual treatment. But there is a paper out of UCLA. I'm blanking on the name of the drug, what they call it, but it's a stem cell product. It's an MSC product. And they gave it to people with Alzheimer's, kind of end-stage Alzheimer's. And at 3 months, they demonstrated new growth in the brain. There was no difference in the dementia, however, but it was only 3 months, and they showed that the neurons started growing again. So I think there may be, promise for the treatment of Alzheimer's. I've given
What are the headwinds you're facing?
The headwinds, it's not approved for me for autism. Autism is special to me because of my son. Most people don't know that we've been using umbilical cord blood and its stem cells in the United States for 60 years, mostly around pediatric malignancies. But now there's 80 different diseases that it's the primary treatment for. So, use it for autism as an off-label, use. But I think that pediatricians and psychiatrists, look down on it because it's off-label. But I think,
do you? Two questions to follow on. Do you ever use autologous stem cells and go through that procedure? A, and B, are you trying to get FDA approval? Are we going to get that?
Yes, I've actually had a Zoom meeting with the chief of staff of the Surgeon General. And it's ludicrous because the Duke study, one of their studies, was with autologous blood. And I haven't been able to use autologous blood, not because I don't want to. It's because none of these banks that are holding the autologous blood will give it up. So even a parent that's paid thousands and thousands to have it banked and then hundreds of years to keep it banked, I can't get it. They won't release it to me. And I think, plus there's a financial incentive for the company not to give it out. And so the parents are flabbergasted that they paid for this and they can't use their own.
Wow.
But I talked to that to the Surgeon General staff.
Well, good. I mean, it sounds like it's moving. It's stem cells are just, it's weird that we haven't been more systematic in our analysis of their therapeutic benefits in all areas. And yet,
I agree.
But so many physicians are starting to use various ideas, because they work. And so people are trying to do, whether it's with the Wharton's jelly or their own autologous, there's all kinds of ways of doing this. And there are all kinds of, maybe you're going to find that intrathecal Wharton's jelly or something is, superior to, who knows what we're going to find.
Right. They tried that. They tried intrathecal.
Oh, yeah? And
I think that the difference is Wharton's jelly is all MSCs, mesenchymal stem cells. And they do have the ability to decrease inflammation with the glial cells. But umbilical cord blood is like chicken soup for healing. And I know you mentioned natural killer cells, but umbilical cord stem cell or umbilical cord blood is filled with natural killer cells, as well as T regulatory cells. So when you give that to a person with a neurodegenerative disease, you're kind of restoring the whole immune system. You're getting T regulatory cells, you're getting natural killer cells, you're getting 7 different types of stem cells, including, the mesenchymal stem cell that's in Wharton's jelly. But I tend to combine the two.
how come there's not immune reaction to that, to the blood?
Umbilical cord blood is so new that the stem cells and the cells within it don't have HLA markers yet. But
the stem cells, I get it. As stem cells, I get it. But I would imagine a T regulatory cell and a natural killer would have markers of some type. That's how they do their job.
But they don't. But they do. The more they work, the more they develop these HLA markers. And which is why we think that the response kind of dies out after 6 months, because the more they divide, the more they make HLA markers, and then the recipient immune system takes them out.
Got it. All right, that makes sense. Well, listen.
I have a question.
Yeah, please go ahead.
Where do you have to drill a hole in the skull to put the stem, or does it go through this?
I
didn't hear it. I'm sorry.
It's an IV. I'm guessing it's just just IV infusion like you had with stem cells. But what we were talking about was what's called an intrathecal injection, which means into the central nervous system, usually into the spine. That's where that goes.
It goes through the spine. Yeah. Okay.
So, but they don't do that. They're not doing that.
Oh, so it's like an infusion.
It's an IV infusion. I find it astonishing that it's one.
The intrathecal is really big in India.
Oh, that's how right? Interesting.
Yeah.
Interesting. I find it astonishing that it's one treatment. My intuition is you'd need 2 or 3, just at least across a couple of years.
No. I'm not saying it's one treatment. There's never been a study of multiple treatments. I give multiple treatments because the parents.
I see. So what is your protocol? Oh, got it. So what is your protocol?
My protocol, real quick, would be to look at some autoantibodies to see what's going on in their immune system. Because they tend to have immune issues. I look at their guts because the dysbiosis in the gut can cause brain inflammation. And so we can treat the gut with something called FMT, or fecal microbial transplant. And then once we got the body as clean as we can, then I give the umbilical cord blood. And then I just reassess at 6 months, and I talk to my patients, and I just say, or to the parents of my patients, and I go, listen, do you think we ought to do this again? Because I do see stair-step improvement, to the point of almost normalcy. Or normalcy, however you say it.
And wait, I'm a little confused. How many infusions does an average child go through, and over what period of time?
Okay, well, first of all, I've only been doing it for about a year and a half, but I would say 40% of my patients come back for a second time, and I would say, right now, 20% come back for a third time. But I don't have too many people who I started out very slowly, so I've got an abnormal amount of people starting in February when I gave up surgery. But
and I got it. And when was your son treated?
My son, he got his first treatment in 2020. I've given him 5 treatments over 7 years, and I see little things. But my son has a significant cognitive disability as well, and so now I'm trying to press IQ more than I am autistic symptoms.
Well, it also makes me wonder the extent, that sigma-1 receptor in the brain. Are you familiar with that biology?
I am not.
It's an inflammatory. Look up there's some really good data actually in the New England Journal about sigma-1, and there's some evidence that antidepressants may work by activating this immune function, this anti-inflammatory sigma-1 system, and it makes me wonder if certain psychiatric conditions, particularly recalcitrant depressions, wouldn't also benefit from this.
I believe it does, and they're starting to look at that, both that and schizophrenia, because it looks like there's inherent brain inflammation in both those. And another exciting thing is chronic pain. Chronic pain looks like it can induce brain inflammation. So I think we're just scratching the surface. I've seen some incredible stuff. I've given 2 people with multiple sclerosis in wheelchairs this product, and they were both walking within 2 months.
Well, I mean, it seems like multiple sclerosis is a perfect sort of paradigm for this. I mean, it's a glial inflammatory anti-myelin. It goes right at this biology you're talking about. Caleb, you want to ask a question about IQ? Why don't you go ahead and ask it yourself? I'll ask
Dr. Weiss, I just heard you say something about how with your son, how now you're focusing more on IQ, and is IQ something that's affected by the stem cell therapies that you're doing now?
There's no study that I know comparing IQ to stem cell therapy. Now, if there was a secondary study by Duke that actually was a negative study, but it turned out they had a lot of children with intellectual disabilities. And if you drew a red line from people with IQs below 70, there was no benefit of the group. But people 70 and above did benefit. So the question is, did the low IQ autistic, did they need a second dose? Did they need a higher dose? Or maybe it just doesn't work.
Or something else going on, something different.
I know my son's biggest issue now is cognitive. And so I have the ability to give it to him.
Well, listen, we appreciate you coming by and telling us, educating me about this and alerting the public to what you're up to. Where would you like people to go if they're interested, if they want to read more? Is there a primary place you'd like to send people?
Probably just North Florida Stem Cells, .com, because I think it's good. I wrote 3 chapters in my wife's book. It's not my book, on kind of the biologic basis of stem cells, and why they work, because most people don't know there's an animal model for autism. Most people don't know when you give these animals, adult stem cells, they get better. And when you start to lay it out, it makes sense to do it.
I have a question. How do they trigger the animal model? I'm not familiar with it.
With inducing inflammation in the brain, like lipopolysaccharide. If you inject that around them
intrathecally.
Yeah, in the meninges.
Got it. Interesting. All right. Well, listen, I really appreciate you coming by. I look forward to your future progress, and particularly with the Surgeon General, the federal government, and the FDA. And let's get this thing rolling here. I think I really think you may be the person that gives this thing a chance.
As I said at the beginning, sign me up.
Oh, Susan wants infusion.
This is, you got to watch people who are on a mission from God, and so I think this is now my passion. I got the time, and I certainly have the energy.
Do you give any sort of anti-inflammatory infusion? Susan did have one down in Central America at one point, and they gave her a huge dose of Decadron beforehand, and she felt so much better. I said, I don't know if that's the Decadron or the stem cells. Yeah. So, are you doing anything like that?
We give a short acting. We give Solu-Cortef.
Solu-Medrol.
But just a minimum, a half a milligram.
Milligrams.
What?
Half milligram per kilo. I was going to say like 20 milligrams, something like that, 20 or 30.
Yeah, that would be high. It's mostly like 6 or 8 because they're kids. But
got it.
But the infuse, just like when you give blood, you usually give a little Benadryl and hydrocortisone just to prevent histamine reaction.
I was just a little surprised at the big dose.
It lasted for a year.
I know she's an enthusiast.
You should have had it done. You gave it to me, and I enjoyed it.
I know. I'm aware. Please keep us. Yeah, I know. I know. She didn't know, but I'm trying to sort out what's what there. So, okay, listen, we have to wrap this up, but I really appreciate you bringing this to us, and I hope you'll keep us posted on your future progress.
No problem. Thanks for having me. I really appreciate it.
You bet, Dr. Eric Weiss. Thank you so much. So I hope you all enjoyed this today. It's a little different than usual. You're indulging me with my peers to talk about some of the advances and the frustrations. And, with COVID, we got sort of monocular in our vision of the medical landscape. And this kind of expands things out a little bit, I hope. So I appreciate you all indulging me, and I hope you'll tell a friend, let other people look at this. I think this is important for people to get a sense of what's going on in medicine and what some of the issues are. Josh Vanderbilt, what do I need to let who talk? You got to understand something, everybody. If I'm interrupting, it's because there's this huge delay, and the only way we can ask each other questions is if we interrupt each other. Now, I would not do that otherwise, so it's apologies that it feels a little jerky, but
also a talk show host.
Anybody that I try not to interrupt.
I mean, if you didn't ask questions, then
I understand, but it's kind of impossible not to step on each other. Like, for instance, one of the tricks I use is if I'm asking somebody a question, I put the question up front, and then I keep talking, and then the other person hears that, and then they're not interrupting me so much because I understand how to use the delay. They don't know on their end how to do that. So I'll go, Caleb, would you mind asking me the phone? Would you say hi on the stream here in just a second? Because I'm still talking. So why don't you go ahead and say hi?
Hi, hello.
See, there's no delay that way. But he heard me say, why don't you say hi a second and a half ago?
See, and
so
you're right, Drew. See, I automatically jumped in like a second before you even finished talking because I just picked up on the trigger. But yeah, I see what you're saying. Anyone on the Zoom call,
I do that.
Right. Just by habit.
Yeah.
I didn't know that.
I actually found this. I found both guests to be very interesting, even though this was like a very more medical of a show. That was very. I've never heard of anyone having any success in the way that Dr. Weiss is having. That's pretty groundbreaking stuff that he seems to be working on. So I was very interested in that.
And the significant inflammatory biology in autism, that the thought bubble over my head was, maybe there is something with vaccines, because vaccines cause cross-reactive immune reactions. And it makes me think, maybe something is going on. Maybe Jenny McCarthy was, after all, really onto something.
And the inflammation connection to everything too. It's so interesting that a lot of this stuff, because I have Crohn's disease, so I think about inflammation stuff a lot. It's really affected my life. And so I'm thinking about, if there's brain inflammation, there could be all over your body from these things.
Emily wanted me to mention Dr. Sabine Hazan and the microbiome and autism.
Yeah, well, I almost said to Dr. Weiss, Dr. Sabine Hazan would be so happy to hear you say that about the fecal transplants that you start out with. You're going to get the microbiome straight before you. I don't quite fully get that relationship between the microbiome and the kind of inflammation he's talking about. And Caleb, you don't want to worry about inflammation all over the body. Inflammation is a very It's a very complicated biology. And when we say inflammation, we're talking about a lot of different things. And in this case, we're talking about a targeted inflammation of microglial cells, which is a certain cell type that's active immunologically and produces cell growth factors in the brain. It's both immunologically active, so it helps prune cells, prune synapses. Happens a lot during puberty, for instance. And it also helps grow cells and keeps cells healthy at the same time. So it's activating those, and how you activate those. He described the pathways that get to the activation of those microglial cells with the exosomes. That's pretty complicated stuff. So it's not like my body's inflamed. It's not like that. It doesn't kind of work that. There is such a thing called SSS, not sick sinus syndrome, sick. Oh, shoot. Well, you had it, Susan.
Don't look at me.
You had it from penicillin. Tell them about that.
I became stiff as a board and I couldn't move from penicillin.
And rash and everything. It just,
I was
just
like,
a mess.
what is going on?
That's
I thought I was
generalized
having a
immune
stroke.
activation. That's what that is. So
I was only in my 20s. I was really young. So.
I know that's penicillin can be nasty. All right, we're going to take a little extendo break here. I'm not really clear on next week's schedule. I know it's a little rocky going
back
forward.
Tuesday and Wednesday.
We're going to be in on Tuesday and Wednesday?
Yes, we're going to be at Elijah's studio in Florida.
Beautiful.
And Emily has guests lined up, and we're all ready to go.
One of the guests is from Hillsides, and I think she's set up there on Tuesday. She's the executive officer at Hillsides, and they have some really wonderful things they're doing now, and I want people to be aware of it. So I'd said, let me put it on the on the blast here. Dr. Victory will be in on the 20th. Steve Hilton, who's running for governor here in California. Skid Row coming up with Reverend Bales and Arthur Kleinschmidt, who's the head of SAMHSA at the, I think that's under HHS now. That's going to be the 28th. We're going to walk Skid Row that day. Well, let me make sure that we have that one. Uh-oh.
Wait, what? What day?
The 28th.
What?
Emily, call me.
Why? What's wrong on the 28th?
I have a gigantic deposition I have to do in Woodland Hills all day.
It's fine.
But Kleinschmidt is coming to town for this.
Oh, crap.
So we can do this.
What time? Maybe we can do it
I wonder
earlier.
if we can do it on Friday, the 29th, if there's a way we could kind of move it around.
We're back to our old habits again of sorting out the schedule at the end of the show.
Discussing this on the air. Yeah, I know. Well, this is a big one. So, all right. Well, listen, we'll get into it. We'll figure it out. Yes, exactly. We appreciate you all so much.
Don't look at me. I didn't do it.
All right. Emily, we will talk. Caleb, have a good weekend. And everyone else have a good weekend as well. We'll be talking to you from Florida next week and then from New York the following week. So we're going to be pretty busy here. We'll see you then. Ask Dr. Drew is produced by Caleb Nation and Susan Pinsky. As a reminder, the discussions here are not a substitute for medical care, diagnosis, or treatment. This show is intended for educational and informational purposes only. I am a licensed physician, but I am not a replacement for your personal doctor, and I am not practicing medicine here. Always remember that our understanding of medicine and science is constantly evolving. Though my opinion is based on the information that is available to me today, some of the contents of this show could be outdated in the future. Be sure to check with trusted resources in case any of the information has been updated since this was published. If you or someone you know is in immediate danger, don't call me, call 911. If you're feeling hopeless or suicidal, call the National Suicide Prevention Lifeline at 800-273-8255. You can find more of my recommended organizations and helpful resources at drdrew.com/help.